How you doing? It's K Medic today. Yeah, welcome to my new series, where I make pretest, pretty much a video. So in this new video series, I'm gonna be reviewing pretest questions for most of the USMLE material. And I'm guessing the whole point of doing this is, first of all, it makes pretest accessible to students who might not necessarily always have time to use the book. But I will definitely have to say that I recommend you getting a pretest book, however you get it. I'll probably say purchase it, to support the company. But I would definitely recommend that you purchase a pretest book for any rotation you're doing, or if you are in basic sciences, probably get it for every discipline you're doing, because they have a pretest for biochemistry, genetics, for psychiatry, everything. So you could definitely take advantage of it, because it's very, very helpful. Pretest questions have been historically helpful for me. So yeah, so I came up with this idea, and I think let's see how it goes. So I'm going to start off with surgery, and let's go right into it. So the question is basically asking the earliest clinical manifestations of hypermagnesemia. The answer is A, loss of deep tendon reflexes. And basically the clinical indication of increased magnesium is the loss of deep tendon reflexes. States of magnesium excess are characterized by generalized neuromuscular depression. Clinically, severe hypomagnesemia is rarely seen except in those patients with advanced renal failure treated with magnesium-containing antacids. You see that? So it's very rare to see that. It's only people with renal failure who are given antacids that contain magnesium. However, hypermagnesemia is produced intentionally by obstetricians who use parenteral magnesium sulfate to treat preeclampsia. So magnesium sulfate is administered until depression of the deep tendon reflexes is observed, a deficit that occurs with modest hypomagnesemia. Greater elevations of magnesium produce progressive paralysis of the chest bellows mechanism. Hypotension may occur because of the direct arteriolar effect of magnesium. Changes in mental status occur in the late stages of the syndrome and are characterized by somnolence that progresses to coma. So basically, there's steps to this, right? And the first thing you're going to see is your deep tendon reflexes. And the last thing you're going to see is it's going to start becoming a mental thing, where now their consciousness, not even mental, it's now starting to affect their consciousness. And when your consciousness starts to become compromised, you know that this person with hypomagnesemia has had this for a longer amount of time. So basically, just know that hypermagnesemia has to do with deep tendon reflexes, losing your deep tendon reflexes, and also it has something to do with your muscles. Hypermagnesemia. Don't forget also that hypomagnesemia is used to induce, right, to treat preeclampsia. Don't forget that. Okay, so the second question, number 2. 5 days after an uneventful cholecystectomy, an asymptomatic middle-aged woman is found to have a serum sodium level of 125. So the sodium level normal sodium level is between 135 and 145. So this person has low sodium. Which of the following is the most appropriate management of this patient? So this patient has low sodium, and it's not just low, it's low, 10 points lower than what low starts with. You see what I'm saying? So it's really low. So what do you want to do, right? Person has low sodium. She had surgery. So it's definitely not E. So the answer is actually B, restriction. So the answer is actually B, restriction of free water. Why? So the initial and often definitive management of hyponatremia is free water restriction, because the person has low sodium, right? So symptomatic in treating hyponatremia, let's just get this straight, right? All right. So normal sodium is between 135 and 145. Okay. Right. But it's when sodium is below 120, you give them hypertonic saline. But remember, when you're giving them the hypertonic saline, you don't want to go fast, because this is when they can get central pontine myelinosis, right? Locked in syndrome. But just know that the first line of treatment, according to Pretest, for hyponatremia is free water restriction. Because the whole point of restricting the water is to activate the renin-angiotensin system, which would thereby activate aldosterone. And what would aldosterone end up doing? Reabsorbing sodium. And with that theory, sodium should increase. So if somebody has low sodium, you don't want to give them immediately sodium. Oh, you have low sodium, take sodium. No, you don't want to do that. What you want to do is, how can I increase the sodium without giving them anything? You see what I'm saying? If you can increase the sodium by just restricting water, that is awesome, because that way you don't even have to now start giving them hypertonic and worrying about central pontine myelinosis. So think about it. Non-medical treatment first, and then you think of central pontine myelinosis, meaning giving them hypertonic saline if the person is under 120 milliequivalents, of course, per liter of sodium. Okay, let's move forward. A 50-year-old patient presents with symptomatic nephrolithiasis. He reports that he underwent a jejunal bypass for morbid obesity when he was 39. Which of the following is a complication of a jejunal ileo bypass? See, if before I answer this question, I see jejunal ileo, right? And I start thinking the ileum, and I start thinking intrinsic factor, and then I start thinking B12. You see what I'm saying? Is this a possibility? I don't know. Let's see the options. So the options are pseudo hyperparathyroidism, hyperuric acid aciduria, hungry bone syndrome, hyperoxaluria, this is increased oxalate in your PP, and sporadic unicameral bone cysts. If you were to ask me, I would probably go with D, just because, like, I'm thinking increased oxalate, usually in Crohn's disease and all this stuff, you can't absorb. But let's see what's going on. 50-year-old patient with symptomatic nephrolithiasis. Yeah, so basically what's happening is the person is having kidney stones. And the person had, they're 50 years old now, but 11 years ago, they had a jejunal ileo bypass. So they had a jejunal ileo bypass, right? So now they're asking you, what is the complication of that? What is causing the stones? And I would say it's increased oxalate, because what happens is that when you are not digesting well, you have increased calcium, and that calcium doesn't get absorbed. I mean, a lot of oxalate gets absorbed, and that oxalate actually goes and precipitates with calcium in your renal tubules, and that's what causes usually the calcium stones, right? But then again, let's see the answer. And that's the answer. So D is the answer. If you want me to, this is what Pretest said. Any patient who has lost much of the ileum, whether from injury, disease, or elective surgery, is at high risk of developing enteric hyperoxaluria. If the colon remains intact, calcium oxalate stones can subsequently develop due to excessive absorption of oxalate from the colon. Normally, fatty acids are absorbed by the terminal ileum, and calcium and oxalate combine to form an insoluble compound that is not absorbed. In the absence of the terminal ileum, unabsorbed fatty acids reach the colon, where they combine with calcium, leaving free oxalate to be absorbed. Unabsorbed fatty acids and bile acids in the colon also promote oxalate uptake by the colon. Subsequently, the excess oxalate is excreted by the kidneys, promoting calcium oxalate stone formation. Do you see what I'm saying? It's pretty much what I said, but I guess in a more concise way. But just remember, so usually in your digestive tract, oxalate and calcium are supposed to bind to each other, and that way now nothing is being absorbed, right? But what ends up happening is if you have too much fatty acids, these fatty acids actually are friends with calcium as well, so they'll go bind with calcium, and then oxalate is left alone. And because oxalate is left alone, it actually gets absorbed, because calcium and oxalate are two things that could get absorbed, right? It's only when they're precipitated together that they're not able to be absorbed by our intestines. But if for some reason you have low calcium or you have high fatty acid, you have high calcium and high fatty acids, right? And they're not digesting the way they're supposed to be because you don't have ileum, right? Terminal ileum. What will happen is that the fatty acids and the calcium will bind together, become friends, and oxalate will be free. Now, that oxalate will then go to renal tubules and do what it does. And of course, you're going to have oxalate stones, calcium oxalate stones. Because, like we said, oxalate and calcium always precipitate. So guess what? They're just going to go do that somewhere else because they can't do it in the intestines. You see what I'm saying? So number 4. Following surgery, a patient develops oligouria. Oligouria means they're not peeing. Or you believe oligouria is due to hypovolemia. But you see corroborative data before increasing intravenous fluids. Which of the following values supports the diagnosis of hypovolemia? Which of the following values supports the diagnosis of hypovolemia? A urine sodium less than 28, urine chloride of 15, fractional excretion of sodium less than 1, urine over serum creatinine ratio of 20. So basically, they're asking us what signifies an AKI, right? But a pre-renal AKI, because of they're talking about oligouria due to hypovolemia. And when we're talking about pre-renal AKI, we're talking about conditions like congestive heart failure, or like any conditions where there's a loss or shock, right? Where there's a loss of perfusion to the kidneys, right? And this in turn now causes in turn causes damage and acute damage and distress to the kidneys. Now, usually we use the lab values to try to determine what kind of, if there is any kidney injury, number 1, right? And then what kind of kidney injury it is. And usually we have the creatinine over bun over creatinine ratio, right? Should be 2-1, right? Which, so the BUN over creatinine ratio will be 2-1. And then typically what happens is that the kidneys in a pre-renal AKI, if you want to think about it, is actually still working, right? Like it's not necessarily the kidneys that have problems, right? The kidneys are fine. So if the kidneys are fine, think about it. The kidneys are fine, so they're going to do what they do. They're going to preserve, right? Because right now there's not much fluid, there's not much volume. So what they want to do is preserve. So because of that, the fractional excretion of sodium should be low, right? Because the kidneys is functioning, and the kidneys function is to save the body, right? And how is it going to save the body in this scenario of hypovolemia? Is by trying not to lose any volume, right? And water is equals to salt. Where salt goes, water follows, right? So exactly why we don't want the salt to go, the sodium. So what we're going to do in this case is say that the fractional excretion of sodium is less than 1, because you would expect the fractional excretion of sodium to be less than 1, because think about it. The kidney is working. Why should it excrete sodium? So let's see. Exactly, and that's the answer. So if that's the answer, there's no reason for me to even read what they say. If you want to see, you have to buy the book so you can see what they're saying, because it won't be fair if I did that, and then how they have to make their money. So you have to read their book. If you don't want to read their book, then you're going to have to listen to my explanations of things, Let's continue. Number 5. A 45-year-old woman with Crohn's disease and a small intestinal fistula develops tetany during the second week of parenteral nutrition. The laboratory findings include, so the sodium is 135, as you can see. You can see potassium 3.2, chloride 103, bicarb is 25, calcium is 8.2, so calcium is low. Magnesium is 1.2, and phosphate is 2.4. Albumin is 2.4. An arterial blood gas sample reveals a pH of 7.42, a PCO2 of 38, which is less than 40. Okay, so we have low CO2, increase, so 7.35 to 7. 4. Yeah, so the pH is okay. So there might be some compensation going on here. Let's see. An arterial blood gas sample reveals a pH of 7.42, PCO2 of 38 and PO2 of 84. Which of the following is the most likely cause of the patient's tetany? So this patient right here has low potassium, low calcium. Okay, albumin is low. Now the question is, which of the following is most likely the cause of the patient's tetany? It is not hyperventilation because of, look, the labs are normal. If you look at the arterial blood gas, it's normal, right? The cause of the tetany, we do know there is hypocalcemia, right? But what is causing the hypocalcemia? Now they're saying essential fatty acid deficiency. It can be essential fatty acid deficiency. It's not a focal seizure. And honestly, the answer is C, hypomagnesemia. First of all, you have to realize that magnesium deficiency is common in malnourished patients and patients with larger gastrointestinal fluid losses. The neuromuscular effects of this condition, right? Low magnesium, because we spoke about high magnesium earlier, of low magnesium, right, resemble those of calcium deficiency. Okay, so that's going to be namely paresthesia, hyperreflexia, muscle spasm, and ultimately tetany. The cardiac effects are more often that of hypercalcemia. So with magnesium, you're going to see like the cardiac effects is going to look like hypermagnesemia, but the muscle effects is going to look like hypocalcemia. So for hypomagnesemia, the muscle is going to feel like they have hypocalcemia, but the heart is going to feel like they have hypercalcemia. And that's why you usually want to use an EKG, right? Because if you use an EKG, a normal hypocalcemia will have prolonged QT interval, T wave inversion, and heart blocks. And hypomagnesemia will have prolonged QT and PR intervals, ST segment depression, flattening or inversion of P waves, torsades. Okay, hypomagnesemia also causes potassium wasting, and that's how I knew it was magnesium, because if I saw like the potassium was low and the calcium was low. If you're big on labs, I would definitely say that you should definitely pay attention to that. If a patient has low calcium levels and they have low potassium levels, you should definitely be suspicious of hypomagnesemia. Also, if you were to do the corrected albumin calculation, you would see that actually the hypocalcemia is actually relatively normal. And how do you do that, you might want to know? Well, this is how I do it and how the book says you should do it, right? So you add 0.8 for every decrease in albumin. Okay, so for every time that albumin decrease, add a 0.8 to the value that you already have, and then compare that, right, to the normal value for calcium and see if the person is still hypocalcemic. And in this case, the person, if I was to add even just 1 or 2 0.8s to the 8.2 calcium level, you will see that it's to be right in the normal range for where calcium is supposed to be. So with that being said, the only answer that this could have been was C, hypomagnesemia. And I hope you guys get the book so you could at least, go deeper into it and practice more. Practice more with me, of course, but you can also do it on your own time yourself, Let's keep going. A patient with a non-obstructing carcinoma of the sigmoid colon is being prepared for elective resection. Which of the following reduces the risk of post-operative infectious complications? A single pre-operative parenteral dose of antibiotic effective against aerobes and anaerobes. B, avoidance of oral antibiotics to prevent emergence of Clostridium difficile. C, post-operative administration for 48 hours of parenteral antibiotics effective against aerobes and anaerobes. D, post-operative administration of parenteral antibiotics effective against aerobes, anaerobes until the patient's intravenous lines and all other drains are removed. And finally, redosing of antibiotics in the operating room if the case lasts for more than 2 hours. So basically, what's this question asking? So the answer is A, a single preoperative parenteral dose of antibiotic effective against aerobes and anaerobes. No later than 1 hour before the procedure. And of course, this is for an elective procedure. You want to give them oral, non-absorbable antibiotic regimen effective against anaerobes and aerobes in combination with a mechanical bowel preparation before elective colon resections. There is no evidence to support the continuation of antibiotics for more than 24 hours after an elective operation has been completed, and this practice should be avoided to prevent increasing microbial drug resistance. For complex prolonged procedures, redosing of antibiotics may be appropriate during the procedure based on the drug's half-life. Broad-spectrum antibiotics coverage, including against anaerobic organisms, is required only in cases where such flora are anticipated, such as during colon resections. So you do not want to just floor them with mad antibiotics, because guess what? They're going to start building resistance. You see? So it makes sense to give them the single preoperative PO dose of the antibiotic, and it should cover aerobes and anaerobes. And it shouldn't be no less than an hour before the procedure. Of course, we're talking about elective procedures. Next question. 75-year-old man with a history of myocardial infarctions 2 years ago, peripheral vascular disease with symptoms of claudication after walking half a block, hypertension and diabetes, presents with a large ventral hernia. He wishes to have the hernia repaired. Which of the following is the most appropriate next step in his preoperative workup? First, A. He should undergo an electrocardiogram. He should undergo an exercise stress test. He should undergo coronary artery bypass prior to operative repair of his ventral hernia. He should undergo a persistent thallium stress test and echocardiography. His history of a myocardial infarction within 3 years is prohibitive for elective surgery. No further testing is necessary. Okay, so the answer is he should undergo a persistent thallium stress test and echocardiography. The patient should undergo persistent thallium stress testing followed by echocardiography to assess his need for coronary angiogram with possible need for angioplasty, statin, or surgical revascularization prior to repair of his hernia. Although exercise stress testing is an appropriate method for elevating a patient's cardiac function preoperatively, this patient's functional status is limited by the peripheral vascular disease, and therefore a pharmacological stress test would be preferred method than a cardiac evaluation. An EKG should be performed in this patient with a history of cardiovascular disease, hypertension, and diabetes, but a normal ECG would not preclude further workup. While myocardial infarction within 6 months of surgery is considered to increase the patient's risk of cardiac complication after surgery, using Goldman's criteria, a remote history of MI is not prohibitive of surgery itself. So you see that? Just because somebody had an MI, yeah, there is an increased risk. Within 6 months, there is an increased risk of having of having complications post-surgery. But this does not necessarily mean that because somebody had a heart attack that they cannot get a procedure. But what you have to do is that you do the EKG. Of course, the EKG is going to be fine or whatever. Well, not always, but like depending on if it's fine and it's just showing, maybe showing pathological QAs indicative of past MIs or whatever. Or yeah, you see like, a funny EKG, but it's showing just past infarction or whatever. It might look fine. So the next thing you're going to have to do is, of course, do a stress test, but not a chemical stress test because this person has had heart problems before. So you don't want to do a chemical stress test for somebody who already has had a heart issue. And that's the reason why they gave us this question, is because of that, and saying that the person had an MI, because they want to stress the fact that first thing is that because someone had an MI, it does not mean that you can't do surgery on them, especially if it's past 6 months and the person is, according to the Goldman Index, they're fine. They could do a surgery. And the second thing is, yeah, that's pretty much it for that question. So you want to do the thallium stress test, right? The percentile thallium stress test and an echocardiogram. Number 8, a previously healthy 55-year-old man undergoes elective right hemicolectomy for stage 1 cancer of the cecum. His post-operative ileus is somewhat prolonged, and on the 5th post-operative day, his nasogastric tube is still in place. Physical examination reveals decreased skin turgor, dry mucous membranes, and orthostatic hypotension. Pertinent laboratory values are as follows, okay? So he has increased pH, he has decreased, no, he has increased pH, he has increased CO2, and he has normal oxygen, okay? His electrolytes, he has normal sodium, he has decreased potassium, he has decreased chloride, and his bicarb is increased. So he has a metabolic alkalosis, right? Because of bicarb and pH. He has a metabolic alkalosis, and this is increased with a respiratory compensation. See that? Let's see. And I could guess what this is. It's like vomiting. Do they vomit? Like vomiting or nasogastric tube, anything sucking the acid out of your stomach, sucking HCl. See, it's sucking the hydrogens, which is the acid part of things, and the Cl. That's why you have low Cl, right? And you're also losing potassium, right? So basically, like this right here is pathognomonic, however you want to say it. This is like this right here. If you were to study, right, and for metabolic alkalosis, you also have, how you look at it in terms of either saline resistant and saline non-resistant, right? When you look at the urinary chloride, if you study these algorithms, it makes these things so easy. Like, that's what I recommend. Like, if you could study the algorithms for all the electrolytes and all the acid-based stuff, half of the questions will be a walk through the pack. See the way I answered this one? It was fun because I really love that stuff. Let's go. Next question. A 52-year-old man with gastric outlet obstruction secondary to a duodenal ulcer presents with hypochloremic, hypokalemic metabolic alkalosis. So he's vomiting or taking diuretics. Which of the following is the most appropriate therapy for the patient? So the first option is infusion of 0.9 sodium chloride with supplemental potassium chloride until clinical changes of volume depletion are eliminated. Infusion of isotonic hydrogen chloride via central venous catheter, clamping the nasogastric tube to prevent further acid losses, administration of acetoalamide to prevent renal excretion of bicarb, intubation and controlled hypoventilation on a volume cycled ventilator for further increase in PCO2. So 52-year-old man, he has gastric outlet obstruction secondary to duodenal ulcer, and he presents with this condition of low chloride, low potassium, and metabolic alkalosis. Now they're asking you for the therapy. We should know that 0.9 is normal saline, right? So we're giving them 0.9% normal saline. And the reason is, you give him normal saline, this will correct the hypovolemia and his metabolic alkalosis. Literally, if you were to know that this person had hypochloremic, hypokalemic metabolic alkalosis, you should also automatically be thinking this person is vomiting. If the person is vomiting, are we going to start doing all this extra stuff? Or this acetoalamide, to promote renal excretion of bicarb? We don't need to do that in this situation. This is not where we do that, right? Like acetoalamide, no, it's not the eye, it's not the brain, it's not proximal tubule right now. We're just talking about vomiting. We're not even talking about the kidneys, you see, which is primarily how acetoalamide works, right? Carbonic anhydrase inhibitor, something like this. Maybe, yes, that's what I believe. So, like, the point I'm trying to make is this. If you look at clamping the nasogastric tube to prevent further acid losses, but what's that going to do to replete the person's volume? So the whole point I'm trying to make is, with these kind of vomiting questions, you want to just replete volume and give them the electrolytes they don't need. And typically when you replete volume, like I said, if it's not less than 120, if they're not telling you this patient is acutely having low sodium less than 120, forget hypertonic saline and forget all that stuff, right? Infusion of isotonic HCl, hydrogen chloride via a central venous catheter. Correction of volume depletion alone is usually sufficient to correct the alkalosis, since the kidney will then excrete the excess bicarb, usually sufficient to correct the alkalosis. Since the kidney will then excrete the excess bicarb, HCl infusion is usually unnecessary. Acetoalamide could be utilized to increase renal excretion of bicarb, but should be avoided in volume depleted individuals. Moreover, so acetazolamide and volume depleted individuals do not go together. Think about it. If somebody has increased intracranial pressure, like they give them mannitol, or what else could they give them? Acetazolamide. Like acetazolamide is a fluid puller, so you don't want to give somebody who has low volume a diuretic. It doesn't make any sense. Okay, so let's move forward, guys. A 23-year-old woman is brought to the emergency room for a halfway house where she apparently swallowed a handful of pills. The patient complains of shortness of breath and tinnitus, but refuses to identify the pills she ingested. Pertinent laboratory values as follows. She has a normal pH. She has decreased PCO2. She has decreased bicarb. So if you have decreased bicarb, decreased PCO2, and everything else is pretty much normal. The pH is on the highest end of things, but this is so right here the person has respiratory. Oh, so let's see. It says compensation here. So usually, like, you could use the Winter's formula, right? Case of metabolic acidosis. And I think it's actually a combined respiratory and metabolic acidosis. Yes, it's a combined. And so let's just go through the options. Using the options, we probably could find the answer. So methanol, this right here, and this right here, these three right here, they all cause metabolic acidosis, right? Mud piles. Right, this is methanol there, and metformin, which phenylformin, I'm guessing, is like metformin. Aspirin is here, but the only problem with aspirin is that aspirin gives you a combined. It first starts off with alkalosis, and that then becomes acidosis, and it's time dependent. And tinnitus, that's aspirin as well. Right, so you see all these three do give you acidosis, right? But with aspirin, there's actually more to the story. It starts off as a metabolic, actually a respiratory alkalosis, and then becomes a metabolic acidosis, as you can see here. Let's see the answer. So yeah, the answer is aspirin. So let's see, tinnitus in conjunction with her mixed metabolic acidosis, respiratory alkalosis. See what I said? It's consistent with salicylate intoxication. Salicylates directly stimulate the respiratory center and produce respiratory alkalosis by building up an accumulation of organic acid. Salicylates also produce a contaminant metabolic acidosis. The patient is in a stage of metabolic acidosis as shown by a markedly increased gap of 28 milliequivalents unmeasured anions per liter of plasma. However, the respiratory response is greater than can be explained by a compensatory response. So basically, you see what I'm saying? So number 11, 18-year-old previously healthy man is placed on intravenous heparin after having a pulmonary embolism after exploratory laparotomy for a small bowel injury following a motor vehicle collision. 5 days later, his platelet counts is 90,000 and continues to fall over the next several days. The patient's serum is positive for antibodies to the heparin platelet factor complexes. So the person is having heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia. Which of the following is the most appropriate next step in management? A. Cessation of all anticoagulation therapy. Cessation of heparin and immediate institution of high-dose warfarin therapy. Cessation of heparin and institution of low-weight molecular heparin. Cessation of heparin and institution of lepuridine. And finally, cessation of heparin and transfusion with platelets. So basically what you want to do is you want to stop heparin and immediately give them a inhibitor, right? You want to give him a factor 10 inhibitor. So what you do is, so it doesn't make sense that you want to give him low molecular weight heparin. So it's not a transfusion thing. It's not a low molecular weight heparin thing. And the reason why I'm saying that, which I might be wrong, just so that you guys don't get it confused, the rationale I'm using to not pick heparin. Of course, we're not about to give this person warfarin. No, but I'm not picking low molecular weight heparin just because it's a heparin product. So maybe we can use it. We'll see. So it's between A and D. Cessation of all anticoagulation therapy, which is not going to happen. You usually want to give them agatrovan or one of them. So I'm guessing luperidine might be a factor 10 inhibitor. And if it is, that is the answer. But if that's not the case, then it will be low molecular weight heparin. Let's see. The answer is yes. So the answer is luperidine. I was correct. And luperidine. Let's see what luperidine is. Number 12, 65-year-old man undergoes a technically difficult abdominal perineal resection for rectal cancer, during which he receives 3 units of packed red blood cells. 4 hours later, in the intensive care unit, he is bleeding heavily from his perineal wound. Emergency coagulation studies reveal normal prothrombin, partial thromboplastin, and bleeding times. The fibrin degradation products are not elevated, but the serum fibrinogen content is depressed and the platelet count is low. Which of the following is most likely the cause of his bleeding? So usually when you have fibrin degradation increase, is C, a bleeding blood vessel in the surgical field. Oh, the parameters are normal there. It's definitely not no blood transfusion reaction because we already know how anaphylaxis works. So and anaphylaxis is not about to start eating your platelets down, right? So basically, what you want to always think and suspect in these kind of scenarios is that like there's been an error in surgical procedure. This is the only way you should think about these kind of questions because everything is pretty much normal because fibrin degradation products should be increased in DIC, and if it's factor 8 deficiency hemophilia, they should know this at 68. Come on, this is not a joke kind of situation. So let's move forward. A 78-year-old man with a history of coronary artery disease and an asymptomatic reducible inguinal hernia requests elective hernia repair. Which of the following would be a valid reason for delaying the proposed surgery? A, coronary artery bypass surgery 3 months earlier, a history of cigarette smoking, jugular venous distension, hypertension, hyperlipidemia. So it will be also carry a high risk, as does the frequent occurrence of ectopic beats, old age, and emergency surgery are risk factors independent of others. So these are the risk factors. These are the core of the Goldman's index, right? The number one most important part of the Goldman's index is the fact that a recent MI has the highest risk of perioperative complications. But we should also realize that this is not the only problem that can occur because of people with congestive heart failure also have a really high risk of perioperative problems. Now, an individual who has hypertension, hyperlipidemia, these are not things that will make us necessarily stop. With smoking, yes, there's definitely a criteria that we have to look at, the FEV over FEV1 ratio or whatever. But even at that, that has nothing to do with delaying a procedure. At least when compared to jugular venous distension, which is a very, very serious situation. They have heart failure, Okay, so let's continue. A 68-year-old man is admitted to the coronary care unit with a acute myocardial infarction. His post-infarction course is marked by congestive heart failure and intermittent hypertension. On the 4th day in the hospital, he developed severe mid-abdominal pain. On physical examination, blood pressure is 90/60 and pulse is 110 beats per minute and regular. The abdomen is soft with mild generalized tenderness and distension. Bowel sounds are hypoactive. Stool Ham test is positive. Which of the following is the most appropriate next step in the patient's management? Person has low blood pressure and increased heart rate. This means hypovolemic shock. Always remember that. Low blood pressure, increased heart rate. Low blood pressure, increased heart rate. Which of the following is the next test? So, the person is losing blood. They're bleeding. I don't think it's barium enema. I think it's angiography just because of it's a bleeding thing. Yeah, so the answer is angiography. Because of this is acute mesenteric ischemia. Patients with peritoneal signs undergo emergent laparotomy. If you do not have peritoneal signs, rigidity, guarding, all that good stuff, then you could get angiography just to see where the bleeding is coming from. But if the person is unstable or they're having peritoneal signs, emergent laparotomy. Okay, next. A 30-year-old woman in her last trimester of pregnancy suddenly develops massive swelling of the lower extremity. Which of the following would be the most appropriate workup and treatment at this time? A. Venography and heparin. B. Duplex ultrasonography and heparin. C. Duplex ultrasonography, heparin, and vena cava filter. D. Duplex ultrasonography, heparin, and warfarin. Whoa. E. Impedance pliosemography and warfarin. You don't want to give warfarin to a child. She's pregnant. Venography and heparin. We could do that. We could definitely do that. We're giving her a vena cava filter. We could. But what's the indication for the filter? Why are we giving her a filter yet? Let's see. Duplex ultrasonography and heparin. I really feel like we have to do a duplex ultrasound for sure. Her legs are swollen. Well, why should I give her IVC filter? She could get an IVC filter, then why is she getting heparin? But then, why not give her an IVC filter? So, because we can't give her warfarin. So, see? I see. The answer is? So the answer is actually B. So you don't give her IVC filter. The answer is B, and the reason why is because duplex ultrasound is a diagnostic modality for detection of infrainguinal deep vein thrombus. Yes, we know that. Although venography is the gold standard, it is no longer routinely used given the risk of local thrombus pain and contrast-related allergic reactions and renal failure complications. Impedance pliosemography, which measures changes in the volume in the lower extremity as related to the blood flow, is used infrequently due to the superiority of the duplex scanning in the DVTs. In pregnant women, anticoagulation for treatment of DVTs achieved with heparin, which does not cross the placenta, rather than warfarin, which is associated with the risk of spontaneous abortion or birth defect. Vena cava filter is not indicated because there is no contraindication to heparin therapy and no evidence of failure of anticoagulation therapy. So the only time you use the filter is when there is contraindications to heparin, because the person already has heparin. So that's why I was kind of like fishy about the filter. It doesn't make any sense. So the answer is duplex ultrasonography and heparin. Okay, let's go to 16. A 20-year-old woman with a family history of von Willebrand's disease is found to have an activated so it's increased PTT and on routine testing prior to cholecystectomy. Further investigation reveals that her PT is also increased, a platelet count of 350,000, and an abnormal bleeding time. So her platelet is fine, her bleeding time is off, her PTT is off, and her PT is kind of off. But the PTT that's heavier than the PT is not that off. Which of the following should be administered in the perioperative period? Okay, so the person has increased PT and increased PTT, and they also have an abnormal bleeding time. Okay, so what do they all have in common is the question. What does the PT, PTT, and the bleeding time have in common? I feel like if we can answer that question, we can answer this question, right? So what can we give this patient here that will activate all these guys to go back up to normal? Okay, because we don't care about the platelets, so we definitely not giving him no platelets. His platelet count is good, right? Vitamin K is only going to work on one pathway, if you really want to think about it, right? But then again, let's think about that. Because of 1972, we always fail to realize that, like, number 2 is in a common pathway. So it can affect, right? It can affect the PT and the PTT. But what about the bleeding time? What are we saying about the bleeding time? Factor 8, right? Factor 8 does not participate in bleeding time. Why is the bleeding time an abnormal bleeding time? Why is the bleeding time also? Well, she has von Willebrand's disease. Oh, it makes sense that she has von Willebrand, so it makes sense. The bleeding time is messed up. Okay, so what would you use to fix von Willebrand's disease? That's pretty much what they're asking. It's not vitamin K. It's not no platelets. does help. I think it's desmopressin. Yes, it's desmopressin, because desmopressin does activate the release of the von Willebrand factor. Physical examination shows a temperature of 39, blood pressure of 150/90, and a pulse of 110 beats per minute and regular. A respiratory rate of 28 beats per minute. A CT scan of the abdomen reveals an abscess in the pelvis. Which of the following most accurately describes his present condition? His present condition. The answer is sepsis. And why? The correct diagnosis is sepsis. Systemic inflammatory response, SIRS, involves two or more of the following: temperature greater than 38, which is 100, or less than 36, which is 97, heart rate greater than 90 per minute, and respiratory rate greater than 20, or PCO2 less than 32, white blood count greater than 12,000 or less than 4,000, or greater than 10% immature neutrophils. Sepsis equals to SIRS plus documented infection. Severe sepsis is equals to sepsis plus organ dysfunction or hypoperfusion, lactic acidosis, oliguria, or altered mental status. Septic shock is equal to sepsis plus organ dysfunction plus hypotension is. So septic shock is sepsis plus organ dysfunction, hypotension. Systolic blood pressure less than 90 mmHg or greater than 90 mmHg with vasopressors. Number 18. A victim of blunt abdominal trauma has splenic and liver lacerations as well as an unstable pelvic fracture. He is hypotensive and tachycardic with a heart rate of 150 despite receiving 2 liters of crystalloid en route to the hospital. He was intubated prior to arrival due to declining mental status. He is taken emergently to the operating room for exploratory laparotomy and external fixation of his pelvic fracture. Which of the following is the best resuscitative strategy? Platelets, fresh frozen plasma. The spleen holds a lot of reticular endothelial cells, and your red blood cells and your platelets, and that being living in your spleen, your reticular endothelial system being lacerated, I would expect that you need some replenishment of your army. Your army being your platelets and your red blood cells. So giving them packed RBCs would probably be a smart idea. In an acute situation, just blunt abdominal trauma, I wouldn't be waiting for labs. I would use my intellect and my common sense. I've already identified the splenic laceration and the liver laceration. Take it from there, All right, let's go. Number 19. A 62-year-old woman undergoes a pancreatoduodenectomy for a pancreatic head cancer. A jejunostomy is placed to facilitate nutritional repletion as she is expected to have a prolonged recovery. What is the best method for delivering post-operative nutrition? So this is asking the best method to give post-operative nutrition. A. Institution of enteral feeding via the jejunostomy tube after return of bowel function as evidenced by passage of flatus or bowel movement. B. Institution of enteral feeding via the jejunostomy tube within 24 hours post-operatively. C. Institution of supplemental enteral feeding via the jejunostomy tube only if the oral intake is inadequate after return of bowel function. D. Institution of combination of immediate trophic enteral feeds via the jejunostomy tube and parenteral nutrition to provide total nutritional support. Complete nutritional support with total parenteral nutrition. What is the answer? Tube within 24 hours post-operatively. Early enteral nutrition is recommended in patients predicted to have a prolonged recovery after surgery. This misconception that the entire bowel does not function in the early post-operative period is still widely held. Intestinal motility and absorption studies have clarified that the patterns by which bowel activity resumes is not what we think. The stomach remains uncoordinated in its muscular activity and does not empty efficiently for about 24 hours. After abdominal procedures, the small bowel functions normally within hours of surgery and is able to accept nutrients promptly either by nasoduodenal or percutaneous jejunal feeding catheters, or after 24 hours. I will leave it there. Number 20. A 65-year-old woman has a life-threatening pulmonary embolus 5 days following removal of uterine malignancy. She is immediately heparinized and maintained in good therapeutic range for the next 3 days, then passes gross blood from her vagina and develops tachycardia, hypotension, and oliguria. Following resuscitation, an abdominal CT scan reveals a major retroperitoneal hematoma. Which of the following is the best next step in management? She has a retroperitoneal hematoma. Stop, heparin, and observe closely will be my answer. Let's see the answer. The answer is A. Immediately reverse heparin by a calculated dose of protamine and place a Vinacava filter. So basically what it is immediate reversal of heparin anticoagulation is indicated in a heparinized patient with significant life-threatening hemorrhage. Protamine sulfate is a specific antidote to heparin and is given at 1 mg for each 100 units heparin. It is given in cases when hemorrhage begins shortly after a bolus of heparin. For a patient, so if the patient just got heparin and now they're hemorrhaging, this is not thrombocytopenia. This is a different situation. This is over heparin, too much heparin, protamine sulfate. That's pretty much what he's trying to say. The book is trying to say. Break.